Beautiful presentation and next case, Ravi. Very nice. Loises, ready?
Good morning, everyone. So let's start with this presentation. Special acknowledgements to Dr. Chaichana, Dr. Almeida, Dr. Ravindran, Dr. Stewart, and Dr. Alvarez. So this is an 81-year-old woman that presented to the emergency department this April of 2023 with sudden onset visual loss and a holocranial headache. Previous medical history was positive for a previously diagnosed large extraaxial mass of the planum sphenoidale and cribriform plate that was diagnosed over 13 years ago and was being followed yearly with serial MRI scans, but no management was taken. Past surgical history was not significant. And in the emergency department, this is the contrast, the CT without contrast. Right here, we can appreciate this large lesion right here over the planum sphenoidale. We can see some heterogeneously hyperdensities within the lesion that are suggestive of hemorrhage. We can also see some hyperdensities within the interhemispheric fissure right here, and some blood also present within the posterior horns of the posterior occipital horns. This CT was also taken, repeated after 6 hours to reevaluate the bleeding. And then at this point, we can also appreciate the natural progression of the lesion over the years. This is the earliest MRI that we have from December 2019. And we can appreciate some slow growth of the lesion over the years. Now, in the emergency room during the physical examination, the patient was alert and oriented, a Glasgow Coma scale of 15. She had elevated blood pressure and she had decreased visual acuity, more pronounced in the right side. And at this point, you know, from visual loss, she had blurry vision, but every other system was negative. And then this pronounced decreased visual acuity in the right side, we can also visualize right here in the ophthalmology report, where we can see more pronounced visual defects in the superior temporal quadrant of the right eye and the nasal quadrant as well. Here, these values, what they represent is the closer they are to zero, the more pronounced the visual defect it is. And we can see when comparing the right eye to the left eye, the right eye has definitely more decline. This is also supported by these values right here, the fixation losses and positive errors. The lower the numbers, the more reliable the test it is. So at this point, the patient was given labetalol as needed for symptomatic control of the blood pressure and IV steroids. And the plan was to proceed with the left pteronial craniotomy for tumor resection, indications where the intracranial hemorrhage that we've seen.
Hold on a second. Do you have images showing the coronal and the axial before the surgery?
Yeah, it'll be right after this slide.
So show us that first, because we cannot plan the approach before understanding the anatomy of this. So show us the axial slowly. So the first thing that you said, I mean, you mentioned that this has been followed as a meningioma. And then the first question that we need to have is this truly a meningioma, or this could be something differently? And the first thing is, you know, of course, for the sake of time, when you think about this, definitely is presenting as a hyper-enhancing mass located in the extra axial space that is well-defined in borders. And the option of a meningioma remains as the number one. There are indeed other differential diagnoses that can include from metastatic disease to hemangiopericystoma to even sarcoidosis, which is not the usual presentation for this, of course. When you look at this, then you have to define where in the skull base is this attaching to. And in your opinion, Loises, where would this be attaching to?
I believe this is arising from the planum.
So where is the planum?
Right,
can you show us?
Yeah. So it's right here.
What is the planum?
So the planum, so we have the sella and then the cella is connected to the planum anteriorly through the tuberculum. So this lesion is sitting right on top of the planum and continuing anteriorly and superiorly over the cribriform plate. So at
I
this
see, but
point,
you still haven't defined what the planum is, right? So the planum, as the name means, is a flat-shaped area in the anterior skull base that defines the roof of the sphenoid sinus. So in this sequence where you were right there, you can go back to it, go back a bit more. No, in the other way around. No, in the coronal, yeah. Okay, stop. So you see here, you can stop right there, please. That this area here will be the plenum, okay? So the plenum, so I agree that this tumor arises partially from the plenum. Move now towards the frontal area, towards the frontal sinus. Keep going the other way around, please. Slowly. Okay, and then you're gonna see, stop there, that there is a component that is attaching as well to the cribriform plate. Okay, so this is an anterior fossa meningioma that arises partially from the plenum, partially from the cribriform plate. Okay, and there are a few reasons why this is important. Now scroll back slowly as well so we can see how lateral this tumor is gonna go. Okay, stop right there. And then I'm gonna clear this just for a moment. And then you see, can anybody tell me what this is here and what this is here? These are bony processes. What is the name of this?
It's in the anterior clinoid.
Anterior clinoid process. Okay. So the anterior clinoid process is located superior and lateral to the optic canals that will become, you're gonna see it better in the next sequence, not in this one exactly. And then you have therefore that this tumor is extending above and lateral to the optic canal into the anterior clinoid process and extending superiorly and laterally to that. So if the tumor extends lateral to the optic canal plane and the optic carotid plane, usually this is not a tumor that will be a great fit for endoscopic and the nasal approaches. If you scroll the image backwards a bit more as well, now we have to pay attention to the vessel anatomy. So go a bit forward just for a moment, just so we can look at the carotid. Okay, very good. So this here is the transition to the supraclinoidal ICA and this as well, okay? And you see that this tumor is, once again, it extends here into the cella to some degree, and then it extends in a supraclinoidal fashion going here. You can start to see some black dots here and here. And as Loises will, please continue moving the slides a bit. You can continue to see those black dots. Go ahead. On the other way around, please. Very good. Stop. One back. One more. So what is this here? Communicating right in the midline. That's the anterior cerebral A1 segment on the right, A1 in the left, and then communicating here as A cone. So it means that part of its tumor will be surrounding those vessels. What is the problem? Often, like, we're not really concerned with the big vessels because they're easy to follow and to identify. But if you scroll a bit more, Loises, on the other way around, you will see that, when this tumor arises and encases the superior part of the acon complex and the posterior part, especially of the acon complex, there is a concern with the perforating branches, the lenticular striates that will be arising from the superior part of the vessel wall and the posterior part of the vessel wall. And that's where resection can become very challenging, depending on the consistency of the tumor. And we have to remember the goals of surgery, the age of the patient, and so on and so forth. The one final important point is the relationship, of course, that we haven't discussed yet with the optic nerves and the optic canal. So Go all the way to the optic chiasm, please. Yeah, the optic chiasm is going to be located backwards, right, Loisa? So keep going. The optic chiasm all the way back. Okay, there you go. You're there. You saw it right there. A bit more. There you go. So this is the optic chiasm right here, right? So this is it right here. And then you're going to see here the pituitary stalk that is arising right here in this edge. And then we're going to have the gland pushed backwards. If you scroll slowly, going towards the frontal sinus, yes. In this image, maybe it's not well representative, but what we had is that the tumor in the optic chiasm, the optic nerves were, displayed inferiorly and laterally by the tumor mass, which represents as well the direction of growth of this tumor. So when a tumor arises primarily from the tuberculum, often what's going to happen is that this mass will displace the optic nerves in a superior and lateral fashion, kind of like opening the arms, but from down up. In this case, you see a mass that is located in front, mostly so in the region of the plenum, and then it's pushing the nerves, and once again opening the arms in a direction from front to back, which is the differentiation hallmark of plenum and tuberculum meningiomas. Okay. Okay, so let's see. Do you have a sagittal?
Yes, right here.
Perfect. So there he goes. Go. Keep going. Okay, stop right there. Right there. So you see, this is the classic point. So here you see this is the region of the cella. Then here, this is the plenum, and this is the cribriform plate. Okay, right in the midline. So you see that this tumor extends almost close to the cribriform plate. It goes all the way up because there is this component of blood and has this relationship here in the back that you can see quite clearly. If you keep scrolling a bit so we can try to identify the vessels that we were talking just now. Perfect. You can keep scrolling, keep going. Keep going the other way around now, sorry. Okay, stop. So you can see that you can see some of the vessels, some of the branches of HU coming in the back part of the tumor. And then like we cannot see really well from this one here. Go to the axial flare. And then in the flare, sometimes it's it's important to observe, of course, the amount of edema. So we can see bilateral, bifrontal edema in this case, which is important to take into consideration because, of course, ideally in our surgical approach, we would like to minimize injuries to the frontal lobe. So with the caveats of the anatomy that we just described, Dr. Chaichan and I, we discussed when we talked about this case, and we had basically at least 4 different options that I can think of right now. One is to go through a frontolateral corridor with a pterional approach. We can go bifrontals with a subfrontal or a transbasal approach. We can go endoscopically in the nasal, or we could even consider an eyebrow approach. The only issue with the eyebrow is that they can be a bit more too forward in my point of view for that type of tumor. An MRA was done that didn't review any signs of vascular pathology that would justify the bleeding. And then the patient, you can go to the next slide. And then, we briefly already talked about some of the differential diagnoses that you represent pretty well. And then I think now you can go back to that indication slide. Yeah, perfect. So please, let's go ahead then.
Yes, so the indication, again, as we said, was for intracranial hemorrhage, clinical and radiographic progression. The goal, of course, was disease control and obtaining some tissue for diagnosis. And then we have the video for the left pterional craniotomy.
Before you start the video, I'm just going to explain one thing. So in terms of the approach was classic pterional with interfascial dissection, and I extended the craniotomy a bit more to the midline, so to allow us to approach the cribriform plate on the ipsilateral side, and also to cut the fox to approach the contralateral side. Number two, such approach, I mean, the video that you're going to see is the microsurgical video. So it does not include the, pretty significant extradural work that was done prior to bringing the microscope, including the coagulation of the extradural space to devascularize this tumor, which supplies is coming from the ethmoidal arteries and then, of course, the meningeal branches. In terms of the selection of the approach, as I said, we could think at least of 4 different approaches. Endoscopic endonasal would not be an excellent option here because of the lateral extension, the amount of vertical size of the tumor, about 4 centimeters, in the encasement of those posterior, in the posterior aspect of the tumor of the cone complex. Eyebrow would not be, in my point of view, at least an excellent option as well, because the tumor is extending a bit too far towards the cribriform plate. And often to get there, in my point of view, you end up benefiting of some endoscopic assistance. Bifrontal approach could be done, could have been selected here. The downside of that is that you may needed to have some mobilization of the bifrontal lobes, and that could lead to potential injury bilaterally. Of course, with careful dissection, that can be approached with minimal issues. But of course, a left pterional approach, an extended left pterional approach, allows excellent exposure with the benefits of early identification of the major vessels on the ipsilateral side. Quite devascularization allows identification prematurely of the optic nerve, or early identification of the ipsilateral optic nerve, and therefore it allows early vascular control that can be used as a roadmap to reach the contralateral side, as you're going to see in this case. So let's see what you have, Oasis.
Hey, JP, the other thing is that we chose the left side too, because there's more edema on that left side, so that we don't have by increasing bifrontal edema. If we chose the right side, obviously the left side is dominant hemisphere, but there's already significant more edema on the left side.
Yeah, absolutely. Thanks, Guy. That's absolutely true. So what you guys see here, of course, can you go back a bit? Just going to show a few things here. Go to the beginning. So this is the left frontal. Okay. This is the temporal here, of course. And you see this is basically working through a subfrontal corridor. And you see the amount of frontal lobe exposed that you have here. So that was necessary so we could get better exposure around the base of the skull around the cribriform plate. You can play the video. Next step is to get CSF release from the basal cistern. So we open in the carotid cistern. And then you see here that I go and try to find the carotid. And then we already have actually the tumor attaching to the plane on the most lateral aspect on the left side. We get tissue sent to frozen. It comes back as a grade 1 meningioma. And then we continue devascularizing that top aspect of the tumor. You need to get, so you see the carotid. We're gonna work around just to get the view, and you're gonna start to see in the tentorial edge the entrance of the third nerve that you can see right there. And then after we get the lateral perspective, so that's the lateral edge of the tumor on the left side, we can go back to the plano. Once again, meningioma. Next step after correct exposure is to devascularize the tumor. So we go to the base and we try to amputate the tumor from the base of the skull. So with bipolar coagulation, we go working around the base, and then we can get all the way to the contralateral optic, all the way to the contralateral carotid bifurcation. Once that's done, you have the major vessels exposed, and then it's to be aggressive with the base of the tumor. Once we're working around the base, we can continue to coagulate and devascularize to kind of try to get the tumor that was connected to the base completely separated, so you only have connections with the frontal lobe itself. So you see here the devascularization and the transection of the tumor taking place. Always, you have always to look at the optic nerve in the carotid so you can keep that plane of dissection. After that was completed, we get all the way to the midline. So we get all the way to the fox. And as we work around the fox, you can see tumor going to the contralateral side. And then here, transecting the fox to get to the right side of the cribriform plate. As we do that, we start coagulating this tumor. And then transecting that component in the contralateral side as well. This patient already had bilateral olfactory dysfunction, so it could be even more aggressive with that area with no additional consequences. So the tumor needs to be vascularized, and we need to get all the way to the contralateral, so to the right side normal brain, it should be able to continue the workout in the dissection. The video is freezing up a bit for me here, but so here we are once again on the left side. So left optic, left carotid. And then now we're going to start trying to mobilize that tumor away from the frontal lobe. And the tumor, as you saw, was embedded in the left frontal and right frontal lobe. So to do that, we're going to need to follow the optic all the way to the optic chiasm. I opened some of the lamina terminalis. That's what was, being highlighted there. And then we see the left and the right optic nerve. And then we're going to also identify at some point, we're going to show the pituitary stalk as well. So opening between the optic and the carotid, lifting up contralaterally. And you see what is showing there is the drainage of some of the hematoma inside the tumor cavity. And of course, a nice amount of clots there. Once the clots are cleared out, then we have to continue our work. And to continue removing this tumor, we got to remember what we discussed in the MRI. To peel that away, we're going to have to identify branches of A2 and also A1. So you see that we're dissecting some of the tumor from the contralateral side, from the right frontal lobe, as you see in the edge right there. But to continue this dissection, we're going to have to go once again from the base and move up. So I believe that that's going to be highlighted in the video shortly. Okay, so we go back to the base, and you see here we're going to have, a lot of the resection of the tumor. And this is just the usual maneuver that we're all familiar with, just pulling the tumor and resecting some of that. Okay, so part of the tumor is removed. Okay, so you see A1 on the left side, and then we're going to have to follow A1 ipsilateral, A1 contralateral. I think that video was shortened a bit since last time I saw it. Anyways, and you see here, I'm using a feather blade to open the optic, the falciform ligament, I'm sorry, on the left side. The same maneuver was done on the right side. And then that was just showing the surgical cavity, the contralateral carotid, ipsilateral optic nerve on the left and the right. And you can see here some of the blood being cleaned, peak on the left, third nerve on the left side as well. You saw a glimpse of the superior hypophyseal. And then you can see here that as we clean that area, you can see the left optic nerve, right, and you had the pituitary stalk for a glimpse in a moment there. Anyways, that allowed the resection of this tumor, and that those steps are important. Just to remember that you have to follow the normal anatomy of the skull base as a roadmap. If you just go debulking extensively with no plan, it's likely you're going to fail. So the plan here was to drain CSF. First of all, good exposure, drain CSF, identify the carotid on the left side, identify the optic nerve on the left side, devascularize the tumor from the base, following the plano attachments. As you do that, you have to go careful to identify the optic nerve and the carotid on the contralateral side. Be careful with the ophthalmic on the right side, so the contralateral side. Once you amputate that tumor, you need to cut the fox, go to the crib form on both sides, and fully devascularize. After that's done, you're going to go to the base, follow A1 ipsilateral to get to the vascular control in the back part of the tumor. Same thing with A1 contralateral. And then you can peel the tumor from its attachments to the base of the frontal lobe. Then you can resect more aggressively and complete your resection. So go ahead, Lois.
Post-op imaging was as expected, with a near total excision and some residual tumor encasing the anterior cerebral arteries. Here we can see some blood products and the resection cavity. And some edema as expected on the flare sequence. Pathology was typical for a meningioma with this characteristic small syncytial cells that form whorls. Was WHO grade 1 meningioma with a very low Ki-67 index. And the outcome, she did very well. She was discharged on post-op day 3 with no acute events and no other neurological complaints. And on last follow-up, her vision was full to confrontation and was overall doing very well. Thank you.
Thanks, Lois. Yeah, nice case. Both Dr. Chechen and I have been following this patient, and thankfully she's doing well. Herself and the husband are very happy. And to remember, she's 81 years old and went through all of that. So we're very, very pleased with the results, with visual improvement, I have to say, after the surgery. Kai, any comments that you'd like to share?
No, that was a good explanation, JP. Good case, tough case.
Thank you. If anybody has any comments about this case or the last case, this is a good time to share pearls. And it's always good to hear from our colleagues. I see Dr. Vargas, I see a number of our colleagues here, but of course, feel free.
Good cases, congratulations. Just one question. Sometimes when we're working on those kind of tumors, meningiomas of the anterior planum, camus sphenoidale, the anterior cerebral arteries are pushing back. And it's not easy by frontal approach or pteronial approach to reach and to separate from the tumor. And in the maneuver, trying to bring the tumor down or anterior, sometimes those arteries can damage. So my question for you is, how do you decide those maneuvers if you don't have sometimes the complete liberation of the arteries, mainly on the upper part or on the back? That's my question.
Well, in my opinion, you have to go from the best way is to go from once you have the carotid bifurcation, and once you have the tumor in the base of the skull exposed as you had from the get-go, you have to devascularize the tumor and then you go cutting it in layers. So I wouldn't start from the top, so where the tumor is attaching to the base of the frontal lobe. But if you go from below, this tumor is going to start to kind of like slowly fall down. Of course, some of them will not fall down and you're still going to have a peel of tumor all the way up. And that's when it's going to be good to have a nice exposure with a flat orbital drilling. I don't think you need an OZ in absolutely most cases, but so you can angle the microscope to look up. And then in my opinion, it's really following A1 to ACOM and then following A2 to be able to get that. If you don't get that nice plane between that and the vessel, it may be risky to kind of peel that away. So I think to identify the vasculature, to safe peel it away as an important part of the procedure. And that's really, in my point of view, when a frontolateral approach has a lot of advantages in cases like this.
Thank you.
Okay, so what's happening on Monday, Diogo?
So we're gonna have our usual ABNS. It will be Dr. Lee and Dr. Fox, then our chairman updates, and then we're gonna have the postdoctoral fellowship day presentations by Paul and myself. So join us Monday, everyone.
Perfect. Thank you, guys. Appreciate it. Nice day and have a nice weekend, everyone. Bye-bye.
Bye.
Bye.